Hello, members of the Macomb County Medical Control Authority. Thank you for attending my talk about endotracheal intubation success versus King Airway success in the pre-hospital setting. The American Heart Association did a study and found out of 202 combined attempts with both the ET endotracheal tube versus the King Airway. The King Airway was used 63 attempts with a success rate of 90% versus the ET tube being used 139 attempts with a 70% success rate by paramedics out in the field. That's a huge difference to me, and it's one of the reasons I'm giving this talk today. This study points out to me, knowing how crucial getting oxygen is to a sick brain or heart, that we can do better for our cardiac arrest patients. An overall question is this advanced skill for paramedics to be doing out in the field causing more harm than good to our patients? Prior to getting them to the hospital where the setting is more conducive for successful intubations. In a hospital, you're on a bed, you have all the lighting, all the personnel you need, all the tools. The ET tube makes a lot of sense in the hospital, but when you're a paramedic, it's just you and your partner. A lot of times there's a lot of difficulties. The main problem being with intubation, our paramedics out in the field, is that a lot of patients are found in precarious positions or situations. I personally have had cardiac arrests happen in hoarder houses where you can barely even get yourself to the patient's side, let alone get them to the floor, have a paramedic go to the head with a laryngoscope blade and get down and look and visually see the vocal cords to get at least a good attempt at an endotracheal intubation. Patients are found on toilets and bathtubs and showers and vehicles. It doesn't make a lot of sense for us to be doing this skill anymore. Even in an ideal situation where they are found on an open floor, often the lighting is bad. There could be no lighting, depending on if you know what type of area you're servicing. There's not a lot of room for the paramedic because the paramedic, as you know, has to lay down at the head to head with the patient to look with the blade and the scope and try to see the vocal cords to get a good shot at success. So the study that I mentioned was a difference of 20% between the ET tube and a King Airway. This is an alarming number, and this was a small study, and if you applied that percentage to a bigger pool of patients, that number would only get higher and more alarming. My solution or recommendation to you is to change the protocol, the airway protocol, to allow the King Airway to be the first choice for paramedics. As it stands now, the protocol wants us to attempt at least twice to get an ET tube successfully. The main problem with the ET tube is intubating the esophagus, tapping the stomach, as we call it. With the King Airway, it's actually designed to go into the esophagus, and the esophagus is where the natural curve of these tubes and the back of the throat want to go to, as you all know, being doctors. But with the King Airway being designed to go into the esophagus, like let me show you here. Now up here, this is the tube. The tube is going to go into the esophagus. This balloon is at a distal point, and it will inflate. You inflate this with a syringe of air. It blows this balloon and this balloon. This balloon will stop gastric contents from coming up and infiltrating the lungs and burning up the lungs with stomach contents. This balloon locks it in place. So right here are your vent holes where your larynx is going to be, as shown down here. And your vent holes, you're going to be venting all into the lungs where the air belongs, and not have any risk of inflating the stomach with an ET tube. If you get into the stomach, you blow the stomach up, all the contents come up, end up going in the in the trachea, and you end up aspirating your patient. And obviously, that is not the goal. So again, with this King Airway, a 90% first-time success rate is pretty good. We need to get these patients oxygen. This slide that I just shown you here, it has the instructions, how to use it, how to remove it, contraindications. I will be giving this to all of you as a handout. And the only reason I'm doing that is I know you all are, physicians in hospitals, and you don't use the King Airway. This is more of an EMS pre-hospital tool. So in my opinion, to be able to go from 70% to 90% is a no-brainer. We need to make it easy for our paramedics out in the street to get these oxygen-deprived patients more oxygen in a timely manner. I have the most confidence in our paramedics, and this is not a knock on them. It's just the nature of the pre-hospital setting and the challenges with this airway skill. Thank you.